Good morning, everyone. Good morning. Great to see you all here. Good morning. I begin by acknowledging the traditional owners of Gadigal land on which we meet today and the Eora Nation. I would like to pay respects to their elders past and present. Now, I call Tony Holland and Kathleen Jones to the stage. Hopefully they're in the room. Yes. While they're coming up, I'd like to thank our bronze sponsors, Karma Germanus Photography, Liberty Care, Lion and Arcadia, our silver sponsors, Multicap, Pfizer, Interaction and Harmony, our gold sponsors, Aardvark Therapies, and our platinum sponsor, Salerno Therapies. Now, I've invited my two colleagues to help welcome you all here today, and I'm going to hand over to you first, if you want to say a couple of words.
Thank you. Good morning, everyone. Look, I want to come back to some words that Deepan shared with us yesterday. And he said, you can judge the character of a society by the way that it cares for its most vulnerable people. And by no fault of their own, our children are the most vulnerable people, and we are all here to care for them. And PWSA is here to provide parent support, and Prader-Willi Research Foundation is here to drive research and access to treatments. And in between there's a grey space. And this is where you see, this is a spectrum. This is a spectrum from care right through to developing future treatments. And so it's been an absolute joy and pleasure to be working with PWSA and the other parent support associations from around the region, not the country, the region. And of course, it's a pleasure to have, well, Dr. Tony Holland here. Couldn't ask for better. So I just thank you for your wonderful collaboration, and I hope all of you have a fantastic day.
And Tony Holland.
Thank you, James. And James has asked me to be part of this welcoming session in my capacity as president of the International Prader-Willi Syndrome Organisation. James and I worked together. That he was vice president for a while whilst doing my stage as president, and it was a wonderful working with you, James. And you brought enormous inspiration to us, particularly around the ECHO scheme and the ECHO project that we had. But I'd like to emphasise very much what you've just said. I think from an IPSO perspective, we get to know people in many countries across the world. And there's a real strength when you come to a country and you see different parts of the Prader-Willi syndrome community, if you like, work together. So I would really urge you to build on that, on what your respective organisations have to offer. Because at the end, in a way, from a research point of view, it doesn't matter where the research is being done as long as it's good research and it contributes to improvements in the lives of people with Prader-Willi syndrome and their family. And I think every support organisation has a lot to offer and to share with other organisations across the world. And finally, I'd just like to commend you too for the Asia-Pacific Rim component. I think that's really good and exciting too, and it's lovely. There's people from Thailand, from Malaysia. We're seeing in China, for example, enormous developments in the support of people with Prader-Willi syndrome. And I mustn't forget New Zealand, of course. And the worst thing, and you're whispering something. And Vietnam, thank you. Yes, Vietnam here. I knew if you start listing countries, the danger is you forget a country. But I would really encourage you to build and develop that relationship between the countries that circle the rim, if you like. So thank you for asking me to be here, and thank you for asking me to contribute to this introduction.
Thank you, Tony and Kathleen. And of course, a very big welcome to all our delegates in the room, our scientists and researchers, our allied health professionals, our families, and most importantly, people living with PWS. You're all very welcome. And online, we have another 70 plus people who are watching today virtually from all around the world. So welcome to you as well. It's now my great pleasure to call Professor Duangru Di Wittinga Sir Shangroon. And forgive me for probably ruining that. More colloquially and known by her colleagues as Professor Duang. So Professor Duang is a paediatric and medical geneticist at the May Hyde University of Ramah, which is located within the hospital facility at that university. She is also Vice President of the Thai Medical Genetics and Genomics Society, co-founder and consultant of the Prader-Willi Syndrome Association of Thailand, co-founder and committee member of Thai Rare Disease Foundation, post-chair of the Medical Genetics Network, Genomic Society of Thailand, and board member of the Asia Pacific Society of Human Genetics. Her research involves clinical and molecular aspects of numerous rare genomic diseases. Professor Duang is one of the leading driving national policy makers to advance services and medical benefits for rare diseases in Thailand. I had the pleasure of meeting Professor Duang in Thailand several years ago, and I witnessed firsthand the respect that her colleagues and her countrymen have for the work she does. So it gives me great pleasure to welcome Professor Duang, who will be talking about a genetic overview of Prader-Willi syndrome. Professor Duang.
So does everybody hear me well? Okay. Thank you so much for inviting me and having me here. It's such a great pleasure to be here. And always I learned a lot when I go to the PWS meeting, which we cannot find the detailed information in the literatures. Because when we come here, we can appreciate the practical point, both from the parents and also from other physicians who have more experience than us. Right? So it's a pleasure to be here and learn too. So my talk about genetics will be quite simple, not very complicated as compared to the yesterday one. So let's start. So Prader-Willi syndrome is a disorder of brain development, especially hypothalamus, and also multiple endocrine problem. And we know that during early infancy, they tend to have problem with low muscle tone or hypotonia. They have problem with poor sucking and feeding difficulties. A lot of oversleep or lethargy and weak cry and delayed development and growth. So when we look at the growth curve, if we do nothing, the infant will have low weight gain, and after 6 or 9 months, they become more alert and eat more and start to, have hyperphagia. And if left untreated, they can have excessive eating and morbid obesity and related complications, such as respiratory problem, obstructive apnea, and cardio problem. There are problems with multiple hormones, hypothyroid, growth hormone, and hypogonadism. Okay. So I need to do both. Okay. Thank you. So in general, each of us has 24 pairs of chromosomes, and that covers more than 30,000 genes. And each gene pair, they function similarly regardless of its parental origin, with the exception of some regions, including a small part of chromosome 15 called it PWS critical region, or 15q11, q13. And in that region, it contains SNRPN, which is important for PWS, and UBE3A, important for Angelman syndrome. Okay. There is another word, genomic imprinting of 15q11. Its definition is that there is a preferential expression depends on the parent of origin, which is exceptional for some part of the genes, some part of the chromosome. And when we look at SNRPN genes that came from the father, highlight in blue and with letter P, normally the genes will be active. But if there is a methylations on the promoter of the gene, it could become inactive. So SNRPN from the father is active, which means the promoter is working. There is no methylations on that promoter. But for SNRPN from the mother, it's usually inactive. We call it imprinted gene or methylated. So the way to make the diagnosis of PWS, we measure the methylation status of the gene. All right. So how does PWS happen? There are three main genetic mechanisms causing PWS, resulting in the lack of functional SNRPN. And 65 to 75% of the patients, it occurs by the error during gametogenesis. It's just accident. There is a deletion of 15q11 that came from the sperm, just that particular sperm, not the others. And that will result in the deletion of paternally derived at 15q11, which means they don't have the active SNRPN. In the other 20 to 30% of the patients, they have two chromosomes, but both came from the mothers. And that's what we call the uniparental disomy from the mother, or maternal UPD. In a very small fraction of patients, which is less than 1%, it is caused by mutation in the genes called imprinting defect. The imprinting genes control the methylation status of the SNRPN, UBE3A, and the other genes in the regions. Okay, this one. So we have to be synchronized. So when we look, when we look closer to, no. Okay, that one. Okay. So when we look closer to the 15q11 regions, we can appreciate that the blue dot represent the paternal-only expressed gene, which if we look closer, there is a SNRPN here and MECL2 and the other genes. And the orange dot represent the maternal-only expressed gene, including UBE3A, which is important for Angelman syndrome. We also see a number of green dots representing biparental expressions. You can appreciate here GABA receptor, B5, A5, and G5, which yesterday we heard some about this GABA receptor in terms of trying to do new therapeutics for PWS. And this is also MECL2 that we heard yesterday from one of the speakers. And the imprinting center is here. It's control the methylation status of the gene in this area. we also heard about deletion, right? So there is a repetitive sequence in DNA sequence of, every one of us on the chromosome 15, we have a repetitive sequence called BP1, BP2, and BP3. And because of this repetitive sequence, it can lead to a accidental deletion, mispairing between the chromosome during the gametogenesis or gamete productions. So the deletion of BP2 and BP3 is called a smaller deletion for PWS or type 2 deletion. If the deletion extended to cover BP1 to BP2 and 3, that's a larger deletion. So there are several types of genetic testing, okay, that we can use. And nowadays, these tests are still being used in some area, in some country as well. And the best test choice for diagnosis PWS is the methylation study. And you can appreciate that by doing MS or methylation study, it can diagnose over 99% of PWS cases, regardless of deletion, unique parental disomy, or imprinting defect. But it cannot differentiate the deletion type from the non-deletion type. Recently, in the past 10 years, there is a new study, new test, methylations. It's a combination of methylation study followed by MLPA. And in this test, once the methylation study reveals PWS, the laboratory will do the MLPA right away. And that way, they can differentiate whether it's a deletion or non-deletion. And it's a small deletion or it's a larger deletion. And that's also covered over 99% of cases. In some countries, in some laboratory, they can do fish analysis or chromosomal microarray, which can detect only the deletion type. And there is another type of chromosomal microarray we call SNP microarray that has a higher yield of diagnosing of PWS compared to the general CMA. DNA polymorphism is not often used but could be useful in some cases. And sequencing is often not used except when we see a patient with PWS but methylation came out negative. Then they have to try to check whether or not this is a representing the mutation in imprinting. Then they will do the sequencing analysis. This is a complex, comprehensive testing that you can find. Sorry. Okay. This is a comprehensive testing strategy that identifies molecular defect of PWS. Most of the time, we can do in the green loop. But after we identify deletion, then it's done. But if we do not identify deletion, right, it could be UPD or imprinting defect. Then the doctor will go for further testing. You can find this information in the genes review. So does it matter to identify genetic mechanism underlying PWS? DNA methylation is sufficient to confirm the PWS diagnosis, but it's not enough for genetic counseling in some way. And also, knowing genetic mechanism could be very helpful in developing future therapeutics for PWS, and also for the prediction of severity of some symptoms. Okay, so talking about the genetic counseling and the risk to the SIP, in general, most cases of PWS is a result of de novo genetic alteration, which means it just happened. Nobody knows why. It's not the fault of the parents, and it cannot be prevented, as far as we know today, right? And the vast majority of the family have a very low risk of having another affected child, so which is often less than 1%. However, always there is no 100% in medicine, right? For case of the deletion, yes, generally the recurrent risk would be less than 1%, but there could be up to 50% in case of the unbalanced chromosome rearrangement. So whether or not the doctor will do that, they will do it. Because after they identify PWS by MS and MLPA, that will help them to identify chromosomal defect. Also, for the maternal UPD, recurrent risk is less than 1%, but it could be up to 1 to 100% in case of translocation of chromosome. Again, the MLPA would be helpful to pick that up. And as for the imprinting defect, if there is a mutation, right? We know that the imprinting defect represents a very small fraction of PWS, but if it does happen, the recurrent risk could be up to 50%. So that's really important. Is there any correlation between clinical manifestation and type of genetic disorder? There is no exclusive correlation has been made now, but there is some statistical significance in the frequency or severity of certain features. For example, the typical facial features, hypopigmentation of skin and hair, and the jigsaw puzzle skill is more obvious in those with deletion type. For patients with maternal UPD, they tend to have higher verbal IQ and have milder behavioral problem. And when we look at the deletions, it was found that those with larger deletion may have poorer adaptive behavior, more of intellectual disability, and academic performance as compared to those with smaller deletion. As for the risk of psychosis, it was found higher percentage in those with uniparental disomy. Also happen to autism. 5 minutes, okay. And so larger study is needed. So if you have PWS database or registry, please go and register on that so that we can have more information. As for growth, 1 more minute. Short stages, if it's not apparent in childhood, it's usually present during the second decade of life in the absence of growth hormone treatment. And the blue line and the pink line represent normal growth spurt that we see in children. However, for PWS, we don't see that growth spurt. The hands and the feet grow slowly and usually less than 50% time by the age of 10. Oops, sorry, I forgot that. All right. Okay, will be my last slide. Delay motor development is quite often. And early milestone achieved usually at about double of normal age. For example, normal children, they may sit at 6 months, PWS children may sit at 12 months, and so on. There is also language delay and intellectual disability and neurophenotype, which we will learn from the next speakers. And that's all my slide, and thank you for all the love. Thank you.
I think we have time for about one question. Would anyone like to ask a question? It looks like you've done a very thorough job, and we thank you for that. It always amazes me every time I see a slide of the deletion zone. There seems to be more detail in there, and it's just incredible how fast science is advancing more recently. And thank you for that wonderful summary of Prader-Willi syndrome.